Good evening, dear colleagues and respected seniors, and thank you, Dr. Vivek and Dr. Sood, for giving me this opportunity. Vivek sir, I have moved on from Homi Baba to Assam Cancer Care Foundation, a Tata Trust operation
Sorry,
in
my
Assam.
bad. I mean, we'll get updated on that. Thank you.
Sure, sir. No problem, sir. So, for the next 15 minutes, I will take to the data that is available on the non-chemotherapy options in advanced triple positive breast cancer. So when we see the breast cancer subtypes, three groups are really distinct based upon presence or absence of these hormone receptor and HER2 receptor. By the absence is triple negative breast cancer subset, and by the presence is the HER2 positive subset. But there is a subset that is in between, that is hormone positive and HER2 positive. So do we need to recognize this as a different subtype and treat differently? As of now, till now, as per the data and for the clinical trials, we are including it as a part of HER2 positive and treating accordingly. So we all know that HER2 positive breast cancer is not really a unique entity. The heterogeneity of HER2 positive breast cancer arises from the presence or absence of the hormone receptors and variability of its percentage of expression. So the differences in the clinical behavior, treatment sensitivity, and intrinsic biology, we know and we daily see in the clinical practice when the hormone receptor is negative and positive. And almost all HER2 positive patients, as of now, are being treated as a singular entity, both in early stage as well as advanced stage, particularly in the setting of clinical trials. So, attributing lesser significance to hormone receptor in HER2 positive, is it acceptable or not? Let's see that. Let's see what data shows for us. So, the optimal management of triple positive breast cancer, it lies somewhere on the border between the pure endocrine therapy and pure HER2 targeted treatments. By majority of the patients are being treated by a combination of chemotherapy plus trastuzumab, depending upon the disease burden. So is there a middle path where we can avoid chemotherapy, which the patient craves through for not having chemotherapy, and we can proceed with the non-chemotherapy options? Let's evaluate. Before going into the data, let us see whether there is a mutual influence of hormone receptor and HER2 on each other. Definitely yes. There is a crosstalk between hormone receptor and HER2 positive family receptors. Whenever there is a anti-HER2 administered to the in the breast cancer cell, there is a reactivation of estrogen receptor signaling as a mechanism of resistance. And we all know that the Ki67 or proliferative index is relatively higher in HER2 positive HER2 positive cancers when the hormone receptor is positive compared to the HER2 negative. So this is the influence the hormone receptor and HER2 have on each other. What are the opportunities we have to personalize therapy in advanced disease setting, particularly in triple positive breast cancer patients? Let us see whether we can get a better result by targeting HER2 arm or hormone receptor arm. So the initial studies I am going to take through to the single agent HER2 blockade along with hormonal therapy. So this is a study which is showing the results of trastuzumab plus hormonal therapy. And the point to take away from this slide is that as the percentage of ER expression increases, when it is greater than 30%, the results of the trastuzumab plus chemotherapy decreases. We can see here in this graph, the PFS, whenever there is in the solid line indicates the estrogen receptor greater than 30%. So the PFS decreases gradually, but in those subset with ER less than 30%, the PFS is definitely better. In those subset where ER and PR both are greater than 30%, you can see the PFS line, it touches the x-axis, showing that the chemotherapy is not doing really good along with trastuzumab in this particular subset where the hormone receptor expression is greater than 30%. One more point to take away from this study is that in those patients who have completed trastuzumab plus chemotherapy in a metastatic setting, the patient who has received the hormone receptor, hormone therapy as a maintenance, they have less PFS events compared to those who have not received any anastrozole or letrozole maintenance. You can see nearly the 24% difference in the PFS events in those who received and who do not receive the maintenance. So this is the trial which is showing the combination of trastuzumab plus anastrozole versus only hormonal therapy, that is anastrozole plus placebo. The primary endpoint is PFS, which is achieved in this study, and 4.8 months in the trastuzumab arm compared to 2.4 months, almost double the PFS by combining trastuzumab and hormonal therapy. Similarly, letrozole plus trastuzumab compared to letrozole, nearly in 1/4 of patients, it was seen that the patients performed better for at least 1 year. But at the same time, in this subset, where combination of trastuzumab and single agent letrozole, nearly half of the patients, they do not have responses, or they do not respond to this combination. Maybe we need a better patient selection to see actually where this combination works. So this is the similar trial, Electra, combination of letrozole plus trastuzumab versus letrozole alone. Although the PFS is really benefit in terms of like time to tumor progression, it is 14.1 months compared to only 3.3 months with letrozole. The OS data is not available for this trial for the reasons unknown. Other HER2 agents that were tried in combination with letrozole were lapatinib. So lapatinib plus letrozole versus letrozole again, 8.2 months in the lapatinib arm versus 3 months in the letrozole arm. The primary endpoint is PFS, and it is achieved in this subset. So can we achieve better results by targeting more HER2 with a better HER2 agents? So this is the trial, PATEN trial, which looked at the same concept of targeting HER2 in triple positive breast cancers in advanced settings, where trastuzumab along with aromatase inhibitor with or without pertuzumab is tested. We can see here the primary endpoint is PFS, and it is achieved in this trial with a difference of 3 months in the difference in the PFS. And when we see the hazard ratio, nearly 35% of events of PFS are prevented by combining pertuzumab in this study. There is alternative trial where double agent HER2 agents were tried along with the aromatase inhibitors. So in this alternate trial, this is a second line trial. There are 3 arms where lapatinib plus trastuzumab plus aromatase inhibitor is the primary arm of interest versus single agent HER2 blockade by trastuzumab plus hormone therapy, and lapatinib plus hormone therapy. When we see the results of this trial, the triple agent arm did much better, followed by lapatinib plus aromatase inhibitor, followed by trastuzumab plus aromatase inhibitor, which is really interesting that lapatinib did much better than trastuzumab. So can we combine even more better agents in the triple positive cancers? Let us have a look at the early local advanced breast cancers. Frankly speaking, there are no separate trials in this group. But when we see the Catherine study, which Dr. Govind Babu sir has elucidated clearly in this in the previous talk, there are 72% of patients who are hormone receptor positive, which means triple positive in this setting. And when we see the IDFS rate, which is one of the endpoints of the study, in the TDM arm, it is definitely beneficial in terms of IDFS 3-year IDFS rate in the triple positive arm with TDM1 compared to trastuzumab alone, proving that the better the targeting of HER2 agents, the benefit it may be more beneficial. But when we come to the advanced setting with the same agent, that is TDM1 in the Emilia trial, where TDM1 was tried against LabCap in the second line setting, nearly 57% of patients, they are triple positive in this trial, and 41% of patients, they have received prior endocrine therapy. And if we see the PFS and OS subset analysis from this trial, we can clearly see that TDM1 fared much better in terms of PFS of 9.6 months versus 6.4 months with the LabCap arm. When we see the overall survival, it is statistically significant difference of 30.9 months survival with the TDM1 versus 25 months with the LabCap arm in this triple positive breast cancer subset. Now the question comes, if we target more the hormone positive arm, can we achieve much more better results? Because we have much better agents to target the hormone positive cancers in terms of in the form of CDK4/6 inhibitors. The trial, this is one of the late breaking abstracts that is presented this year, which is Monarch-HER trial. This is a phase 2 study which has looked at combination of abemaciclib plus trastuzumab with or without fulvestrant versus only trastuzumab plus standard chemotherapy. When we see the statistically the efficacy analysis, definitely the abemaciclib, it has done much better in terms 8.3 months versus 5.7 months. So this forms effective non-chemotherapy option in patients who are seeking for non-chemotherapy options in triple positive subset in advanced setting. There is one more interesting abstract that was presented in the combination of CDK4/6 inhibitor plus AI plus trastuzumab. This is the palbociclib, the agent which is used in here. But they have stratified this hormone positive patients by using PAM50 luminal intrinsic subtype, and they clearly defined which are really hormone positive or not by using this microarray of PAM50. When we see the first safety run analysis, that was the final analysis data is not available in this study. But when we see the first safety run analysis, it is proved that it is safe and active in this subset, palbociclib arm along with aromatase inhibitor. Also, this paves the path for the better stratification and better selection of patients when we use costly therapies like CDK4/6 inhibitors by using the molecular stratification like PAM50, where we can get a better results by selecting the exact hormone positive patients. So coming to the conclusions from these trials, there is a substantial lack of specific trials in this triple positive subset. And we know that a majority of HER2 positive tumors, they are excluded from the endocrine trials, and the HER2 targeted agents often done the analysis without seeing for the hormone positive and hormone negative as a pre-planned analysis in majority of the trials. But we can see that increasing evidence that there are differences in the outcome between two subsets of hormone positive and hormone negative HER2 positive cancers. This is the summary of the triple positive breast cancers. Various agents used, which we already discussed in the first line and second line. Whenever we target the HER2 compared to aromatase inhibitor, and they are definitely doing better. The PFS is better. And when we combine trastuzumab and pertuzumab, and when we use the more potent HER2 agent, the PFS is much better. We can see here in the potent trial, the PFS is 27 versus 15.1 months only with the trastuzumab. In the second line, we have already discussed the alternative trial where the triple agent of trastuzumab, lapatinib, and aromatase inhibitors is done better, followed by lapatinib plus AI, followed by trastuzumab plus AI. But the interesting combination will be where we can actually combine these CDK4/6 inhibitors along with the potent HER2 agents like pertuzumab, tucatinib, and neratinib. These are the ongoing trials in the same lines where we can see that after 2 or more lines, the endocrine therapy is being combined with the ribociclib, palbociclib, and along with the trastuzumab and pertuzumab. The results can be quite interesting with much more benefit in this particular subset. There are other trials which are testing pyrotinib, tucatinib, as well as neratinib in the same lines. With this, I conclude my talk, and thank you so much.